the sort of things you can take with you into the OSCE as well, and they're true for every radiographic procedure. So as I stated before, in terms of what we confirm with the request form, well, it isn't really about you guys making a judgment on whether or not the referral was justified by a number of measures which you can find online or in fact in the Image Pathways site. So it's not about you guys questioning GPs, specialists or emergency physicians at all. At this point, it's all about you guys making sure the request form makes sense. All the things match. You've got the right patient, you've got the right history, you've got the right area requested, and even simple things like it hasn't already been performed. And this can happen. What you'll find in the hospital situation, this can happen. Something is performed, but the request form is left lying around and someone goes to do it again. They bring the patient down to do it again and the patient doesn't say anything. The patient thinks, oh, it's just a follow-up. There's all sorts of things can go wrong. So basically, what you confirm is nothing more than does the request form make sense and are we doing the correct procedure? It hasn't already been done. And that's really it. And the next thing is room preparation. Now, room preparation basically means that your room is ready to receive a patient. So normal room preparation would be things like ensure that any artefacts from the previous patient have been removed. And you'll find you'll collect several mobile phones, you collect all sorts of things. People leave things. So one of the most important things you do in an X-ray room is ensure that you direct patients. A patient will walk into an X-ray room and they've got all sorts of paraphernalia. A phone's the most important thing, I suppose. And they'll just put it wherever they can find. The best way to deal with that is to make sure the patient takes every single thing with them into the change room and leaves it there. Don't get them to scatter things around the room because almost certainly they'll walk out and they'll forget several of them. So what it's about is you directing patients. The patient doesn't know what to do, they don't know where to put their things unless you direct them. So it's all about you direct them to take everything with them and you direct them where to put them initially. But room preparation is nothing more than having a room in a situation where you can bring the patient straight in and you actually want to minimise the amount of time the patient's in the room. And you'll do that by wiping down any patient contact surfaces beforehand with an alcohol wipe. They're all patient contact surfaces, so for example in a chest OSCE, the fascia of the buccal and the chin rest. Any patient contact surfaces wiped down and make sure pretty much everything's done. Have your SID set, have your buccal centred, have the table moved out of the way so the patient has adequate room. Don't have your table moved right up towards the buccal because the patient's got no room. Give the patient as much room as possible. Move the table right out of the way, get everything set up as best you can. So it's all about having every single thing you need prepared so the patient has a minimal amount of time in the room. Because what happens, and this happens in life too, when you guys first start, you'll be a bit nervous dealing with patients and you'll forget things. So the more you can do before the patient arrives, the less chance you've got of forgetting something. You can even do things like stick your marker on the outside of the buccal tray. And that's another interesting thing. What I find, whenever I use an erect buccal, I'm very reluctant to put a marker on a cassette. And the reason why is because if they fall off, they're buggers to get out. So I generally put all markers on the erect buccal on the buccal itself. Only for the fact that they tend to fall off. In the buccal tray it doesn't matter so much because it's flat, so the marker isn't going to fall off. But erect, the markers often fall off. If they fall off inside the buccal tray, they are buggers to get out. They're really hard to get out. So you might like to consider that. So, as I say, table buccal, marker on cassette, But a rect bucky, I think it's better to put them on the outside. And you can say why. You can say that's because I don't want to run the risk of the marker falling off. And it's very common. A lot of radiographers do it. Now, how do we prepare our patient? Well, of course, we identify the patient by 3 different methods. We explain the procedure to the patient, and we get some elements of history. And that element of history not only might give us some extra information on how we're going to perform the procedure, and it may well be that it's contrary to what the doctor has told us on the request form, or it's additional too. And that may direct how we're going to perform the procedure, but also too, it's a way of confirming we've got the right patient in the right situation. And then of course it's getting patients changed. And remember there's a bit of a golden rule with getting patients changed. What do we remove? Well, we remove nothing that's medically applied until we ask, but everything else, remove more rather than less. Don't compromise things by saying, oh look, maybe it'll be okay if I just do this. Always remove more rather than less, because you end up getting artefacts on your cassette, on your image, and they are reportable. The radiologist reports everything on the image. So remove more rather than less. So when in doubt, take it off, I say. Well, how do we prepare ourselves? Well, the most important thing is to speak as clearly as you possibly can. Try and speak a bit more slowly. You don't have to yell at patients. And in fact, one thing that's quite interesting, patients that struggle to understand you because they're hard of hearing or may even have a English as second, third, fourth, fifth language, they don't need volume. What they need is just slowing things down. And the other most important thing too is lack of background noise. And my father was a typical example of this. My father who became very deaf as he got older, he was fine speaking normally to him, providing there was no background noise. It's background noise that is difficult for people who don't quite understand you as well as they should. So the way you speak with patients is slow down, you don't have to yell. And the other thing is too, what radiographers always do, we tend to become quite animated. And that's because we're dealing with people all the time who are not as responsive as we might like because they're sick, they're injured, or they've got all sorts of other issues, a lot of them language. So radiographers tend to be very expressive. I'd like you to come this way, thank you. I'd like you to stand up against the rect bucky. And you can even demonstrate what you want them to do. You can even demonstrate. Don't worry about that because that's what a lot of radiographers will do. So we tend to be overly animated to both position. We physically must position them, touch them and position them, but also too to be very animated in the way we describe things. Now, of course, for your OSCE, how are you prepared? Well, you've got to wear clinical uniform. Have you guys got markers yet? Still haven't got them yet. What's clinical saying? Any chance they'll have them by the OSCE? We don't know. We'll see. I'll speak with Laura again today. But the most important thing about your chest OSCE, and the one thing where you can make things go horribly wrong is this. You'll move your tube out of bucky. So what you must do is move your tube, lock it into bucky, send it to the rect bucky, and then remember, once you've done that, all you can then do is move your tube up and down. That's it. Do nothing more than adjust the height of your tube. You then must move your patient, because if you move your tube out of bucky, even by 2 centimetres, the examination will fail. You've got to be centred really close to the centre of the bucky, or the image won't work at all. You've got a tiny amount of latitude, so don't do it. Remember, once you've sent it to bucky, unlike extremity radiography, once you've sent it to bucky, you must move your patient, not the tube. The only tube movement is up and down. Really important. Now let's talk about patient presentations. And that's the range of people we might see. And this is still pretty general stuff before we get to the wrist and forearm. But why these things are important is because this dictates how you're going to manage the situation. Here's a little old lady. She may well have come from casualty and she'll be rugged up because she's in shock, she's broken a wrist. Typical old lady's fracture, Colles fracture, she's fallen over and fractured her wrist. Now this happened to me, a situation like this happened to me when I was a young radiographer, but it was a lady across the road at home. She fell over and she had a Colles fracture, and I could tell straight away it was typical appearance of a Colles fracture. And I was only in my mid-20s, I was only fairly young, just starting in radiography. But what was amazing is the amount of shock she went into. She started to tremble, she got cold, and I helped her up, and the first thing you do is get them to sit down. Patients that are old and injured, they can collapse with shock. In fact, anyone can collapse with shock. So be careful. You're dealing with an old patient in this situation with a Colles fracture. Not only may she well have osteoporosis, so in other words, she's at risk of many things, but she'll be cold, she'll be trembling, and she'll be in a degree of shock. So you need to cater for that as well. In this situation, you'd make the call of whether you get her into a chair or whether in fact you just leave her in the wheelchair. And you'll make that decision based on the nursing escort that's with her and just your own assessment. And the nurse may well say, look, she needs to stay in the chair, she's a bit unsteady. Then of course at the other end, you'll have little babies. Now this actually is my nephew. Does he look a bit like me or not? And he's a little girl. Now you wouldn't believe it, not long after this x-ray was taken, this little girl broke her femur in an accident. Terrible. Broke her femur. She's okay now, but what's remarkable is how asymptomatic she was. In other words, it wasn't that obvious she'd done it. So sometimes with children, you mightn't know. Usually in older people, like it's quite obvious, you can see the distortions, what have you, that this was a femur she broke, but it's amazing. Sometimes you can't tell with children what's going on at all. So just be aware that you have this enormous range of presentations, and often clinically it's more difficult with children. Children can mask things. Adults are more predictable. So let's get back now to what we're talking about today mainly, and that's radiography of wrist and forearm. Very, very common, both of them. And of course our SID is 100, as it is in all radiography apart from chests. No grid or Barkey. Exposure range, well, it's the exposure range for extremities. 50 to 55 kVp, 5 to 15 MAS. And that's pretty much our range for all extremities. So what do you reckon a wrist might be in that range, if that's your range? I would probably use 10 MAS, so 100 MA for 0.1. I'd probably use 50 for the PA, 55 for the lateral, and what about the oblique? Halfway. Makes sense, doesn't it? 50 and 55, so how about I go halfway for the oblique? And that's generally what you will do. You don't do that with a finger because the finger's round, but a wrist isn't round. Does that make sense? And of course we change exposure in relation to anatomical thickness. Now it is probably fairly important that you learn the 8 bones in the wrist. There's all sorts of little sayings to remember that, by the way, but I don't particularly like those. Just remember them. Look at it and say them to yourself a dozen times and you will remember them. It's only 8 things, but it's important to know them because often in your history there'll be some suspicion of what's broken, although, generally speaking, clinically, no one will know apart from a fractured scaphoid. A fractured scaphoid is really distinctive in terms of how it occurs. It's the mode of injury and also, too, the patient's complaint of their pain. The other bones, well, they're not as distinct, so often they won't know. It'll be query fracture. So it may well be these bones are fractured, but more commonly, the scaphoid will be fractured, or, in fact, the radius and ulnar. So radius and ulnar and scaphoid, and less commonly, all the other carpal bones. You need a pretty dramatic or a more high force injury to fracture any of these other carpal bones. So what you'll immediately assume in most fractured wrists is either a fractured radius or ulnar or both, or fractured scaphoid. Now these are basically the three projections you'll perform of the wrist. Actually, those two are the same. So what has happened there? Something bizarre has happened there. These are actually two obliques. But in any event, guys, look, just understand where those 8 bones live. And look, the best way to do it is just, say to yourself, as I say a dozen times, and you remember, they're pretty simple. I think that they're one of the anatomical things that you need to know. You need to know the 8 carpal bones of the wrist. Now let's talk about technique. So the patient's presented to you, and you don't really know where the fracture is, but you're going to assume it's either scaphoid or it's radius and ulnar. It may be the other carpal bones, but you don't know. But generally speaking, when you receive a request form, the doctor will say, query fractured radius and ulnar or query colles. It's very rare you get just X-ray wrist, that's it. It'll either say, if it does say X-ray wrist, the request will give some elements of history, so it gives you some idea. And it'll say X-ray wrist, query colles, or query fractured radius, or query fracture both. So the history will always combine with what's requested, and you'll have at least some idea right from the outset in what you're X-raying. And once again, you can ask the patient too, where are you sore? And you might be able to see, if you've got a fractured radius and ulnar, a colles fracture, almost always there is a degree of angulation which you can see. And so you'll know it's radius and ulnar. So the standard technique in Australia is 3 projections. And what you'll notice is, when you speak with Steve, when you see Steve, he will tell you often, a series without obliques. And that's because in England, they tend not to do obliques. So when Steve tells you his technique, that's not a bad thing, because it shows you the techniques worldwide can vary a bit. In Australia, we tend to do obliques. In England, they don't. So that's why Steve will tell you different things. So if you go and work in England, don't do obliques. If you work in Australia, do obliques. Interesting, isn't it? So the setup for a wrist depends on the size of the patient. So generally for all females and children, I'll use a 24-30 and I'll do 3 projections on the one cassette. PA, oblique, lateral. And it fits well. And once again, we do it by the method that I explained before. Set our collimation and then don't touch it. Just lead rubber on the other parts, expose, lift the patient up, slide the cassette along, down, anatomy down, expose again, patient up, cassette along, anatomy down, expose again. And don't touch your collimation. Try and leave it all as much the same as you can. And for women and children, or smaller males, That's what I'll always do, three projections. If you've got a really large guy, that won't work. So what you'll do is you'll put two projections, PA and lateral on, PA and oblique on one, and lateral on a third cassette. And once again, the reason why you'll do that is because always try and have two things in the one cassette that are most like each other, where there's, in terms of anatomical thickness. Because you can't separate reconstruction algorithms over a cassette, in other words, in this case, what algorithm will you pick? Will you pick a PA, an oblique, or a lateral? The answer is it doesn't matter. It doesn't really matter what you pick because they're all so similar. And the same here. Whether you pick a PA or an oblique, it doesn't matter. And you pick a lateral for that. But what happens is, when this cassette is read, whatever program you pick, whatever body part you pick for its algorithm, the program will try and optimise all the information on the entire cassette. And so it will average out the best appearance for the three things. And that's fine, it'll work well. But when you've got two on the one cassette, for example a PA and a lateral, it would try and average out PA and lateral density and give more of a compromise. These PA and oblique are almost the same, so it doesn't matter. So whenever you can, the anatomy that's thickest, try and put on its own cassette so the computer program can basically optimise that separately. Do you know what I'm saying? Try and keep anatomy as similar as possible on the one cassette because only one algorithm evens things out. In this case, because you've got three, you find that it works quite well. But with two, it's more problematical. So PA and oblique and then lateral. So PA, oblique and lateral, our three standard projections. Now, they're not that hard at all, just a couple of little things, we finesse. So where do we centre, first of all? Between the styloid processes. Run your finger along to the end of your radius and ulna and you'll feel two protrusions. Right at the very end. Those two protrusions are your styloids. We feel those, or we can actually just see them, and we centre in the dead centre of them. It's pretty easy. But one other thing as well. Put your wrist flat on the table, your hand flat on the table. And what do you notice? Notice that your wrist is elevated a bit off the table. Now draw your fingers up and your wrist should fall down onto the table. So bend your fingers up. You don't have to make a fist necessarily, but just drawing your fingers up a little bit makes your wrist fall flat. So you're reducing object to detector distance, which is a good thing. A sharper image, but also less chance of movement. So bend your fingers up just slightly to get the wrist down on the cassette. That is really the only thing for the PA. Now the other question is, how much do we include? And this will vary in different departments. It'll also vary depending on whether it's pre or post surgical, or whether it's a follow-up. Usually in initial studies, we will include all of the metacarpals as well. All of the metacarpals, so obviously we'll include that same distance the other side as well. Some textbooks say always include a third of the long bone. But I don't think that's that important. Just from mid-styloid So collimate end of the metacarpals, and obviously it'll be the same distance the other way too, and that's what you include. And that's an initial study. Having said that, for a follow-up, you don't need to include that much. You can include, 2/3 of that. If, for example, your follow-up is post-hardware being inserted, like pins or plates, then you have to include all of the pin or plate. And so that'll dictate how big your collimation is, by what hardware has been inserted by the orthopaedic surgeon. And the other thing that happens then, follow-up imaging post-surgically, 2 views only, PA and lateral only, no oblique in follow-ups. Now an oblique's just, by definition, a standard oblique is midway between a PA and lateral. So a standard oblique is 45 degrees. There are some exceptions, but generally speaking, a standard oblique is midway between PA and lateral. It's 45 degrees, and that's done. It doesn't matter. You don't need to bend your fingers up anymore. Just turn your head on 45 degrees. And a foam is the best option to maintain that position and also keep the patient still. And include exactly the same, just head of metacarpals, that's what you'll include. The head. So, in other words, what you want to include is just the full metacarpal. If you miss a bit, it doesn't really matter. But that's sort of the default. We just extend to the knuckles and the same distance the other way. In fact, including all of the knuckle if you can.
Sometimes with the obliques, it's hard to get the thumb in as well.
No, well, the thumb, that's an important, I'm glad you brought that up. The thumb doesn't matter in an oblique. You don't include the thumb in an oblique wrist. You do include it obviously in an oblique hand, but not in an oblique wrist, you don't include the thumb. So it's pretty much as you can see in that diagram. And there's another important point here as well. Now, in theory, you still centre mid-styloid. But remember, when you oblique something, to actually centre mid-styloid, you have to centre more towards the thumb at the skin margin. So, in fact, you will be going through the mid-styloid. And you'll notice that in this diagram here. That does look like mid-styloid, doesn't it? But when you think about it, by the time it's penetrated through the patient, that beam will exit mid-styloid. So its exit point will be mid-styloid, even though its entrance point isn't. Can you all see that? I'll turn the lights out because this is really important, because you'll get caught with this. And it's something that'll catch you out all the time with doing obliques. And you'll say, gee, if I set it mid-styloid, my collimation's not right. And remember this, that basically your anatomy needs to be in the centre of the collimation. So can you all see here that, in fact, that doesn't appear to be mid-styloid at all. It's way over towards the thumb. But its exit point, once the primary beam's gone through the patient, it will actually exit the patient mid-styloid. And that's an important point. And even if you can't quite wrap your mind around it now, we can have a look this afternoon in the lab and I'll explain further why that's the case. So, in other words, in an oblique, where you actually centre, the entrance point is not the same as the exit point. Enters there, exits there. And that's why you can get confused. But basically, your anatomy needs to be in the centre of the radiation field. Now, the very last image is your lateral. Now, your lateral wrist is actually not that hard to achieve, although there is one major trick to it. You guys just put your hand on the table in what you think is lateral position. So your hand's lateral. When your hands, and that's what you do, straighten the fingers and say, okay, the hand's lateral. Bring your thumb down, your hand's lateral. Once you've achieved that, then roll back about 3 or 4 degrees. It's not much, 3 or 4 degrees, and then your wrist is lateral. So most people, when they perform a lateral, don't get a lateral because they've got the hand lateral. So when the hand's lateral, then roll back 3 or 4 degrees, not much, and then your wrist will be lateral. And you'll achieve this, great superimposition of the radius and ulna. Now, one thing that's quite interesting, notice in this case, the patient's got their arm bent. And that's fine, but my view is I prefer to perform laterals with the arm straight. I think they're easy to achieve. And I'll show you why in a moment. In reality, in practice, you'll need to do both. But in a wrist, a perfect lateral is the most important thing. If your PA and oblique aren't perfect, it's less important. Your lateral, it's vital it's exact because that is what a treating casualty officer or an orthopaedic surgeon will go on in determining what needs to happen. For example, if you break your wrist, it may well be that it can be fixed in casualty by the doctors there. They'll fix it. And it's all about degree of angulation. How much is your bone bent? If it's not bent at all, in other words, if you can see a fracture but the alignment is still perfect, a doctor in casualty will fix it. They'll plaster up and they'll send you off. And an average healthy adult will be fine in 6 weeks. So off you'll go, your wrist is all bandaged up in plaster, and in 6 weeks it'll be fine. Usually halfway in that period you'll have a check x-ray. So just an AP or PA and lateral. But if you have angulation, if it's only a little bit of angulation, it may well be that they might leave it. But if it's significant, more than about 15 degrees, then it requires something more. It requires orthopaedic treatment. So an orthopaedic surgeon will get called in and they will need to what's called reduce the fracture. The word reduction means return to normal. They'll need to return your fracture to normal. They'll need to return alignment to normal. And that's why this is so important, because this is how the doctor in casualty will determine whether or not he needs an orthopaedic consult. You need to be then looked after by an orthopaedic surgeon who will reduce your fracture if needs be, if it's more than 15-degree angulation. So an absolute lateral is really important in the wrist. So remember, hand lateral, roll backwards 3 or 4 degrees, and it'll work. And basically what we're trying to achieve is something like this. Our 3 projections. lateral, oblique and PA. It doesn't really matter how you present them, in what order, but they need to look something like that. And generally speaking, you'll find with 3 projections on the same cassette, obviously the lateral gives you the most space to put a marker. So this patient's been reasonably well collimated and the anatomy's reasonably well lined up as well. But the obvious space for your marker, because it doesn't really matter, is where the lateral is, because you've got this dead space here, which you don't have on the other 2 projections. So lateral's a good place for the marker. Now when it comes to the other option for a wrist, it's called scaphoid projection. So there's only 2 ways we perform a wrist. Either we just do the standard 3 projections, PA, oblique, lateral, or we do the scaphoid technique. Now the scaphoid technique will almost always be asked for because the doctor's made this determination that there is a scaphoid fracture. And clinically you can determine that really, really easily. This is a really old-fashioned thing, but in the early days of radiography, they used to call the scaphoid, or how we located the scaphoid, was by looking at the anatomical snuff box. Anatomical snuff box. What on earth does that mean? I didn't quite get it, but apparently back in the 17 and 1800s, people used to sniff things. And they used to put it in that little dent in their hand. Put their stuff there. I know you guys do different things now, don't you, I think? I don't know. I don't know. That's what they used to do, so they called it the anatomical snuff box. And so sometimes you hear that term, it's a really old-fashioned term, it's a meaningless term, but that in fact is how you locate it. It's in there. And it's a really quite a common injury, and it's clinically very easy to determine. So the doctor will, any decent doctor will know, yes, it's a scaphoid fracture, almost certainly. And so you may be asked for a scaphoid series. Or sometimes it might say, X-ray wrist, query fractured scaphoid in the history. So then you'll do a scaphoid series. Now a scaphoid series is not that bad because you'll use a 2430 cassette, but this time divided into 4, and the reason why is because you'll collimate a lot more. In other words, you know that it's nowhere else, the fracture almost certainly, so you don't include as much. You collimate right down, so you've got 4 areas on the one 2430 cassette, and what you'll do is just put the patient into those 4 areas. Once again, move your cassette around. Now the good thing is the first three projections are pretty much the same as a normal wrist. A PA, an oblique and a lateral, but tightly collimated. Now you may ask, well, where do you centre? Centre just a little bit superior to the styloids. Oh, sorry, a little bit distal, not superior, distal, a little bit distal to the styloid. So it's about a centimetre distal. So feel the styloids go up, and don't centre on the scaphoid, centre on the whole lot. And you'll find a lot of people get confused. Where do you centre? Include the whole lot. And the reason why is because you want to make sure there is no fracture anywhere in the carpal bones. And you may well have a fractured scaphoid, but a fracture somewhere else as well. And this tends to be one of these areas where people have different views. My view is don't centre on the scaphoid at all, centre on the carpal bones, because you're looking at all of them, even though almost certainly the scaphoid is the injured one. So I always centre a centimetre distal to the styloid and include all of the carpal bones. So your PA, the only difference is this. Put your hand flat on the table bend as if you're doing a normal PA wrist. Draw your fingers up a little bit. Then all you do is ulnar deviate. Turn your wrist towards the ulnar. That's all you do. Just how much? Well, just a relaxed amount. Don't overdo it. Just don't force anything, because anything you force, the patient won't hold. So just turn your wrist towards the ulnar. And what that does by doing that is it opens up the scaphoid. That's ulnar deviation. Obviously you can't do that with the oblique or the lateral, but with your PA, just ulnar deviate. So your first three projections are pretty much the same, apart from the PA with ulnar deviation. But your extra projection, and look, there are a range of extra projections, but the most common, I'm not going to give you all of them because there's several, and really almost everyone does this one. And it's ulnar deviation plus tube angulation. So the tube is tilted to project up the arm. How much? Well, it depends. There are a range of options there too, but it's a PA with ulnar deviation and tube angulation, as shown below. Yep.
I was just wondering, like, because you're collating a lot out of the radius of the ulnar, what
Yeah.
percentage of scaphoid fractures would also have a fraction radius?
It's quite rare, actually.
Yeah, okay.
It's interesting. It's interesting.
It could be common.
No, it's quite interesting because it just tends to be that one thing breaks, and that's it. And a scaphoid fracture with a fractured radius and ulnar is rare. It happens. I mean, everything can happen, but that is not the most common thing you see. Scaphoid is almost always by itself.
Makes me worried that if you
And
chose to do that, that you would miss the radius of the ulnar.
well, you'd include a bit more than this. You see, that is not a good example of what you'd include. You'd include a little bit more than that. So you actually get it in. You actually do get the radius and ulnar in. So that is not a good example of what you actually include. And that's what you say is why I recommend don't ever over-collimate. Always have a bit of a margin around everything, just in case the doctor's wrong. So in a normal scaphoid, you will in fact get the radius and ulnar. Now, how much you angle there? The most common is around about 25 degrees. And what it will actually do is elongate the scaphoid. So angulation elongates things. But people tend to have their own methods, but about 20, 25 degrees is about what most people would use. And you get this elongated scaphoid, and it's actually quite a good projection. Now we come to the forearm. Well, let's first of all think about what sort of exposure we might use. So if we adjust exposure relative to anatomical thickness, is your forearm thicker than your wrist? What do you think? It is, isn't it? So what do we use for the wrist? 100.1, 50 to 55. So what do you think you might use for wrist? We don't really want to use much more than 55. I'd probably use 0.15. So I'd probably use 0.15 for 50 and 0.15 for 55. And that'll give you a pretty good image. Because all we do for forearms are PAs and laterals, or APs and laterals. We only do APs and laterals. We don't do obliques. We don't do obliques and we don't do PAs. So why do you do a forearm, if we do a wrist PA, why do a forearm AP? We don't do a forearm like that. We do AP and lateral. And the way we do that is by either putting a cassette, a 24-30 cassette, and collimate on the diagonal, or we can do two projections both on a 30-40 cassette. Now, why do you think some people might use a smaller cassette and put it on the diagonal? Once again, the smaller cassette, better image resolution. And this is, I tend to do this, I tend to use a smaller cassette. But for a really big patient, you know, a 7 foot tall patient with long arms, where this doesn't work, use a 30-40 to do that. But generally speaking, for most people, I use a 24-30 on the diagonal. And you'll collimate and one cassette each. AP and lateral. Now, why do you do an AP and lateral? We do that because simply, if you do a PA, your radius and ulnar cross. To separate them, we need to go AP. So if you do PA, you look at a PA forearm, your bones overlap. They cross. So AP separates them. And it's quite straightforward. The arm straight, resting on the cassette, rolling outward slightly. And what you'll normally do is you'll put a sandbag over the patient's fingers to hold them in place. It is not a difficult position at all, but like all positioning, always minimise the amount of time the patient has to hold a position, because they won't. They'll only hold it for a certain amount of time, then they'll move. So this is why everything's done beforehand, including exposure. You position, you walk out, you expose. So it's pretty straightforward. Extend the arm, roll back slightly, sandbag on the fingertips to hold them there. Then what do you include? Whenever you're doing any long bones, you must always include both joints. So collimate to 1 centimetre past both joints. And the reason you need to do that is because you need orientation points. If you were just to x-ray a long bone without both joints, you wouldn't know exactly where the fracture was. But if you've got two joints on, you can orientate where that fracture is exactly. So always include both joints on long bones. Now, most textbooks will tell you this is what we do. We do an AP like that, there should be a marker on that, and we do a lateral like that. And the reason why we do that is because by rolling the wrist back slightly, and we roll the wrist back a little bit, those few degrees, to get a lateral wrist. And also too, if we do this properly, with the axilla or the armpit as low as possible too, we'll get a pretty good lateral elbow. But the problem is, the radius and ulnar aren't superimposed. And this is one of the big decisions in radiography. Do you perform a projection of a lateral forearm, so you're actually getting a pretty good lateral wrist and forearm, although you're not having superimposition of the radius and ulnar, say in the centre? So these are the standard projections. But many times I won't do this. I'll actually straighten the arm out. By straightening the arm out, you aren't getting a lateral elbow at all. You're getting a lateral wrist, and then the radius and ulnar are totally superimposed, but you don't get a lateral elbow. And that's a much better idea if you've got a mid-shaft fracture, particularly after it's been plated, after it's had surgery. And I'll show you why in a moment. So there are your normal projections you might have performed. There's your AP and your lateral, pretty much as textbooks require of you. And they're both on 2430 cassettes on diagonals. Why? Because small cassette, better resolution, got a marker, that's all good. This patient, by the way, has got a little extra pathology. It's got a bit of a spur there. Bony spurs, they happen everywhere. And I'm sure most of you will get one in your lifetime. But that's pretty much what you'd expect. But look what happens if you've got a patient that's had surgery. What will happen then is the patient's had this arm plated, and what the orthopaedic surgeon will want to see is the alignment of those plates. And these are a couple of my very old images. So what I've done here is I've done a standard AP, and that's fine. And you can see you've got both joints on, and you've got pretty good separation of radius and ulnar, and here's the plate. But if I did a normal lateral, the problem is the plate wouldn't be lateral. So what I've done is a straight arm lateral. I put the arm dead straight, roll the wrist back 3 degrees, 3 or 4 degrees, and I've got superimposition of the radius and ulnar. And that is better post-surgically. So in fact, you do them both ways. Does that make sense? And now I can see that these haven't copied very well, but I can see now that I can't see that plate at all, which is in fact what you want to see. I know that plate's and that bone's in perfect alignment. So sometimes you do that post-surgically, keep the arm straight. And in fact, sometimes you'll have no choice, because a lot of patients, maybe with a broken forearm, have other injuries as well, and they can't, and their arm is just naturally straight. For example, if you're on a trolley, if the patient's on a trolley or on your table, because they've got, once again, polytrauma, many things that are wrong. So the patient's lying supine. A supine patient, he can do an AP and a lateral, no problem. But you can't do that. So this straight arm lateral are for patients that are supine, or often post-surgically it's a better option. Does that make sense? What do you reckon looks best? I reckon these look better because it looks like a lateral, but the problem is the elbow isn't lateral. So you will need to do both at some stage. So carpal fractures, they occur because of compressive loads to a hyperextended wrist. So, in other words, people fall over on their wrist. Now, and of course, it hyperflexes. Now, even though the older you are, the more chance that it can happen, funnily enough, you see a lot of scaphoid fractures in young people. Classic example would be something like at a skate park. Riding a skateboard at a skate park, classic example of how you get a scaphoid fracture. And it says here that officially scaphoids are 60 to 70%. I would question that. I think it's more. I would say there's more than that. This figure I got from someone who's an associate professor here, and my view is that it's more than that. So sometimes we don't agree, but it doesn't really matter. All you know is overwhelmingly scaphoids are the most common. And this is what scaphoid fractures look like. But there's one important thing about scaphoid fractures. Very often scaphoid fractures, at the time of injury, they might have clinical signs of fracture, but you can't see it. You perform your routine views, you can't see it. But clinically, the patient has both the pain and the clinical signs to indicate a scaphoid fracture. But because it's only a hairline fracture, you can't see it. And this will happen. So what happens in that case is that the patient's often told to come back in 2 weeks for re-X-ray. And they might be treated clinically as if they've got a fracture. They might be given even plaster at that point because you can't see this hairline fracture. But what happens is, after a period of 2 weeks, bones have repaired quite a bit. And what you get is the establishment of a thing called callus, C-A-L-L-U-S, callus bone formation. Now, callus bone formation is the bone repairing itself. So, you can see this density at the side of the fracture, which is callus bone being laid down to repair the fracture. And you see this density line through the scaphoid, so you know there is a fracture. And of course, that's why we can know when we find archaeological skeletons whether people have had injuries. So you can examine, for example, if you were to find a 2,000-year-old skeleton and you dig it up and it's got big callus bone formations, multiple through arms and legs, where the patient's been in a sword fight, for example. And you might say, well, okay, there's also a few bits out of the skull as well. What killed the patient? What killed the patient? Well, if there's callus bone formation, they've healed. So in other words, if anything that was an old fracture that's healed with callus bone formation, and you'll see it on a skeleton, it'll be there forever, you'll say, well, okay, that didn't kill them because unless they died many months later of an infection, for example, but it's actually healed, so they didn't die at the time of the injury. But if you were to find a skeleton with these massive bony injuries, but no evidence of healing, no evidence of bone callus formation, you'd know they died pretty much at the time of the injury. Does that make sense? And so you see, if you go to Europe or England, where they've got these old-fashioned, where they've got old skulls and things, you'll see some skull injuries where there's just really crisp cuts in the skull with zero repair. They died at the time of injury. Or some other injuries with a bit of callus bone, no, they survived. So it's interesting. Now, one word on collimation. Collimation is best, of course, when it's done just right. But we do tend to go one way or the other. If we over-collimate, well, we risk missing anatomy and pathology, particularly in soft tissue, so we don't want to do that. Now, under-collimation, which means we haven't collimated enough, so realise it's the opposite of what you might think. That is over-collimation. You've over-adjusted, over-minimised. Under-collimation is you haven't done it enough. You haven't collimated enough. Collimation is the act of setting the size of your radiation field. So over-collimation is you've been too enthusiastic, under-collimation not enthusiastic enough. And under-collimation, of course, increases dose, scatter, and decreases quality. If in doubt, it's better overall not to miss things. Because if you miss something, you've got to do it again. If you end up with a result like this, you wouldn't repeat it, you'd just be aware that, look, it's not optimal. But in this case, you've got to repeat something. So don't collimate to the point where you have to repeat. Because remember this, that the best radiation safety you can give your patient is by not doing repeats. And while we're pretty radiosensitive these days in terms of, radiation dose to patients, and we're helped with digital imaging, and we're helped with the minimisation of number of projections we do, still the best protection you can give your patient is no repeats. It's way more important than anything else. So don't over-collimate and risk repeats. Once again, the post-operative technique, and this is true of all parts of the body, it's just 2 projections at 90 degrees, and here's a classic example of what you might do. In this case, a PA and a lateral wrist, and these are a couple of my images, and I remember this patient. And what you'll see here is the patient has a couple of things. First of all, they have a number of pins in their arm, and this is quite common. Now those pins won't stay there, they'll be removed at some stage. But you must make sure you get all of the pins on, because the orthopaedic surgeon will want to see the entire pin, because sometimes these can break. And if they break, they need to know. So that's why you get all of the pins on. But there's another thing you'll notice about this. Notice here it looks a bit of a funny appearance. And what's this density here and here? Well, it's plaster. It's plaster of Paris. So post-operatively, when you x-ray something like this, and this is what you want to include. I've included a lot here because I didn't quite know where the pins went. So what happens post-operatively after a major surgery like this is the patient is secured in a cast. And that can be one of 2 types. It can either be plaster of Paris. Plaster of Paris is the white stuff. They mix up and put on the patient, or it can be fiberglass. There's 2 options. And they both have different pros and cons. Fiberglass is rough. It's got a rougher finish. But the advantage with fiberglass is it's more resistant to moisture. So while you shouldn't get either a plaster of Paris or fiberglass wet, fiberglass is a bit more resistant to moisture and water. Where plaster of Paris is not at all. If you get your plaster of Paris wet, apart from the fact it'll deteriorate, it'll go mouldy and start to smell. But the big difference is, in terms of patient, well, plaster of Paris is probably a little bit more comfortable in some ways, although there's a gauze put between the skin margin and the cast anyway. But fiberglass is very hard and rough. But the big advantage, of course, with plaster of Paris for kids is you can write on it. You can write your name, you can draw on it. That's a massive advantage for kids. So kids like plaster of Paris because you can write on it. You can't write on fiberglass. But in terms of what a radiography, look, both things are used. And surgeons have their preference, and it'll depend on many things. So it doesn't really matter. But radiographically, the difference is this. Fiberglass can often put a texture over your image, a texture that I don't like. It's often more difficult to see discrete fracture lines through fiberglass than plaster of Paris, because plaster of Paris tends to give a more even appearance over the image, where fiberglass gives a more patterned appearance. But the other difference is this. Fiberglass is not very radio opaque. What that means is that you don't need to increase your exposure much at all. Maybe a couple of kVp, 2 or 3 kVp increase in exposure for fiberglass because minimally radio-opaque. Plaster of Paris, on the other hand, is very radio-opaque. So you may need to increase your exposure quite a bit. And it will depend on how thick the plaster is, but you may need to increase your exposure up to 10 kVp. So you may find this is one occasion where, in fact, you'll use an extremity technique, but you'll go beyond the upper limit of what you normally use. You may well use 60 kVp for a plaster of Paris wrist. So that's the big difference. So fiberglass increases a couple of kVp, plaster of Paris 5, 6, 7, 8, 9, 10 or even more, depending on how thick the plaster is. Adjust your collimation as necessary, and then you come up with something like this. Now notice something here. I've got a pretty good PA and lateral. So how have I done that when I can't see the patient's arm? And of course I can't, because the patient's in plaster of Paris. I can't see the arm. And the reason why I've got such good images is because I've used the fingertips. I can see the fingertips. I use the fingertips to determine whether when I'm PA, I get fingertips lateral, I roll back 3 degrees. I've used the fingertips to position my patient because that's all I can see. And that's what you'll do. Because the plaster will usually come up to about here. So you just use fingers to orientate. Now, what do you think is the story with this patient? This is a very, very old image that I took years ago. So you've got to ask yourself what's going on here. This is a very complex image, and I'm glad I got it because this has multiple things going on. And in fact, this was taken before digital radiography. So this is an old-fashioned radiograph, which I've copied. But what's going on? There's multiple things. Well, the first thing you notice here is something that's, well, I suppose you notice several things. But first of all, what you can see is these zippers. What are they? Those zippers are part of what's called an air cast. So in other words, it's basically the arm has been secured with an inflatable cast. And you'll often see these, and you zip them up. So it's a bit of plastic which you can inflate, and that holds the arm in position. So it's basically, what it is, it's an emergency way of securing a potential fracture. So an ambulance might do that. An ambulance might see the patient and say, look, there's a fracture, so I'll put this air sling or air cast on, and you zip them up. They're just plastic filled with air, and they'll keep the arm in place. So the first thing you know from this image is that this is, whatever's happening is happening now. Like this is a trauma case that's coming. But what you can also know is this patient has had previous injuries. And that previous injury is this very, very nasty fracture of the radius and ulnar, which has been plated. So this was done some time ago. So you've got this injury, a plated radius and ulnar with a terrible break. And in fact, what do you notice about this? Something really quite odd. The damage was so severe that what they've actually done is they've connected the distal radius to the proximal ulnar. And this is why this is hard to understand. The radius, so it's half radius, half ulnar, because the damage was so extensive. So the story here is, this patient was previously assaulted, and he had multiple injuries, but his arm was, as you see, just really deliberately broken in the nastiest way possible. And he had surgery. And so in the surgery, his radius is now connected to his ulnar. So this is a compromise to try and give him some functionality, because otherwise he's got no bone left. And this was done some time ago. So the problem was, this guy didn't change the company that he kept. And the people who did this came back at a later time, at this time, and shot him with a shotgun in the arm. Undoubtedly it was something to do with drugs. A drug deal that went very wrong, someone didn't pay his debts. So, his current injury is being shot by a shotgun. So this was the first time they visited, and this is the second time they visited. They shot him with a shotgun. So pellets everywhere. Now most of those pellets would have gone right through him. So the reason why we're x-raying him now is to see what's happened with his bones. But obviously you can imagine this would be a situation where there'd be a lot of blood, but he's in this air steam, which is great because that's protecting me a little bit as well. So what do you think is going to happen with all those pellets? Will they come out or will they leave them there? They'll only remove the ones that are causing problems. Most likely they'll leave them there. And you'll still see this occasionally actually with veterans from war as well. They'll have bits of shrapnel in them which are too difficult to remove. And this may be a case where those things are too difficult to remove. And who knows, he might have had a third visit by now, if he's still alive. What's interesting is this guy had more movement than what I would have imagined. It's amazing what people can do. You know, he'd obviously, this had happened, there'd been some gap in between the first and the second visit by his friends, but I was amazed that, you know, he was able to do something, you know. He was actually able to move his arm more than and even after he'd been shot by a shotgun, and he's in a sling, I still managed to be able to move him reasonably well. But so just sometimes you see these most bizarre things, but then you put the story together. So guys, if you're going to buy drugs, pay your bills. Maybe there's a better option not buying them in the first place, I don't know. So that's really quite dramatic. Now, we'll go through and have a look at a few things in your prac book now. So this afternoon, we'll get in and do the wrist and forearm. Look, the wrist and forearm's easy to do. The only complicating factor, I suppose, is the scaphoid, but we'll go through the prac book quickly now. So this afternoon, we'll knock these over very quickly and then we can practice some chest as well. So I'll just quickly go through the other things. Oh, you can see by looking at it, yeah. And of course, I went through his notes. This is another thing too. I went through his notes to see what happened. I thought, this is bizarre. And so you go through patient notes to see what the history is. Yeah. I'm going to get a stiff neck, guys, because the screen's not working. So I've got to turn around and look at this screen. Okay, guys, so quickly just run through the pre-practical tasks for today. And look, you guys can answer these questions. How do I manage a patient who is blood contaminated? Well, you know. Number one, protect yourself. Put gloves on. And the most important thing of all, of course, is that you clean up before and after. But anything that you contaminate with blood must not go into a garbage bin. It goes into contaminated waste. Really important, don't put anything with blood in a normal garbage bin. It goes in a contaminated waste bin. Now, contaminated waste is quite expensive to get rid of. And that's why you don't put anything extra in there. Like the cost of contaminated waste removal is extraordinary. But that's why only stuff that is contaminated must go in contaminated waste, but then you must do it. If you put that in normal garbage, then the cleaners are at risk. So don't do that. It must go in contaminated waste. And protect yourself, number one. Your gloves. Take every precaution possible. And of course, the next question is just there for no other reason than preparing you guys for a possible end of semester multiple choice question on this very thing. And so if by now you can't see obviously which is the best option and explain why, you've probably got a bit of a problem. You should be able to each look at those three exposures and say, yes, one is clearly the best one. So without me saying anything, can everyone see why one is best and why the other two aren't optimal? Who can't see the problems with two and why one's optimal? Okay, guys, for the very last time, I'll let you know. The first thing is, do you notice that all of those exposures are equivalent? They're all equivalent, aren't they? Because they're all 10 MAS and 50 kVp. So they're your options. So, okay, this one's great because look at the short time. That's great for stopping movement. But the problem is 500 MA is broad focus. I've lost some image resolution. This one, well, it's fine focus. That's fine, but the time's too long. This one is just right. It's the biggest fine focused, so it's kept my time fairly short, and that's why. So that very simple decision shows you understand exposure selection. So there are three equivalent exposures, exactly the same quantity and quality of X-rays in both cases, but number B is the best option. Make sense? Now this is to make sure you are listening. So if the patient has been immobilised, should these be removed? You should know the answer to that by now. Remove nothing medically until you check. Now notice something here. These are a couple of questions to prepare you for next week. And so I'll go through those next week. A fat pad sign. That's something that you need to know for next week, and we'll talk about that. Because these are the sort of things which may also be in an exam. A fat pad sign. A fat pad sign is something we look for in the elbow. So come next week and I'll answer that question. And that one. And that one. That's why I've got to come next time, which will be actually week 6, and we'll answer those questions. So these are just examples of a few little things that might be in an exam question. So I'll answer all of those in our next class, which will be week after the radiation risk lecture. So they're just examples of the sort of things you might be asked. Now let's have a look at a bit of pathology. or a bit of critique. So what's wrong with that image? It's damn difficult to look at, isn't it? Don't make the mistake of having the wrists and elbows at different ends of the image. So put both your wrists and both your elbows at the same end. A radiologist will have nightmares trying to look at that. Don't make their job difficult. So don't ever do that. Don't mix your cassette up and get it upside down in one image. So your AP is not bad. What's up with the lateral? It's reasonable lateral elbow, but look at the wrist. They haven't rolled their hand back those 3 degrees, 3 or 4 degrees. And that's what happens. That. So keep that up the other end. Now this is a great example of that little old lady that I showed you. This is what that little old lady in the first slide of today's lecture, that's what she would have. A nasty, nasty Colles fracture. Very osteoporotic bones, break very easily, nasty fracture. And so you may well find you can't get a perfect lateral because of the degree of fracture. But obviously that's going to need major surgery, and that's what you might see. And that'll, of course, that'll have massive soft tissue ramifications as well. You'll be able to see that the bone's fractured because the arm will look like that. It'll be quite dramatic. In fact, you'll find that in not long at all, I reckon in 9 out of 10 cases, you'll know whether someone's got a fracture by looking at them. And you'll become very good at it. Probably more than 90% of cases, you'll pick a fracture. And that'll happen within probably 1 year of radiography. Now, just quickly, next time, what we're going to do is do this very quick technical exercise. And then we'll practice for the OSCE. So our practice next week is this. So I want you guys to have a look at this between now and week 5 and try and work out what that's all about. And just try and have a go at answering those things. And I'll give you the answers to those in week 5, but most of our prac will be basically just OSCE practice. But have a look at that between now and week 5 and try and work out what I'm saying. And like I say, don't wait solely till I give you the answer, because I want to see whether you guys can answer that yourself now. So I want you to tell me honestly, if you can't answer it, let me know in the prac class, okay? Because it's for my own benefit to see whether I've got you guys up to speed adequately or not. So please try that before then. Okay guys, that's about it. So have a break. Steve will be along fairly shortly. And once again, this afternoon we'll go through and do those wrists and forearms, but we'll do chest OSCE practice as well.
That's right, good person. I spoke with Laura in regards to ongoing to graduation.
Yes, what did Laura say?
I saw her last week, she says that's okay, but she still sent me an email to confirm.
Yeah.
She's going to do it 4:45 on Tuesday at 10.
Oh, that's fine.
Yeah.
That's fine. Yes,
So,
I can do that too. No problem. Yeah.
I'm just wondering, can I do some of the practice this week?
Yeah, absolutely.
If you got time after,
Yeah, absolutely. What time's the prep class?
afternoon, 3 o'clock.
Yeah, certainly. Yeah, I'll stay late. Sure. So say 3 to 5. So yeah, do it after 5. Yeah, I'll say that for an hour or so. No worries with you.
Thanks.
Yeah, okay.
Would like to say for the opening age, the three choices are all of them are equal, but I'm not pretty sure why. I mean, with the high MS suitable.
Because high MA equals a broad focus. X-ray tubes have a fine focus and a broad focus. A fine focus gives you better image resolution.
Okay, so with the high MA we will both focus and like worse image resolution.
That's right, yeah. So, just so happens that every X-ray tube sends its current to either a big filament or a little filament. And the big,
you mean the beam of the electron is thick. I mean thicker than the last MA. So
yeah. Look, in an X-ray tube, you've got a big filament and a little filament. And all the big MAs send to the big filament, big MAs send to the little filament. And the little filament impacts on the anode to focus what with a smaller size than the big one. In fact, the big filament has an area that produces twice the size of the area. And the bigger the area, the bigger the focus spot, the less the resolution.
okay. Thanks.
I can see that the wrist is clearly dislocated.
Yeah.
Or would you say it's a fracture?
Yeah, that's a fracture. It's broken up, broken on up there.
Right.
You see it's broken.
So both will something like this.
Yeah, as you can see that's where it should be. That should be back here. So that's the radius there.
Yeah.
That should be back there. Yeah. So that's a really nasty fracture.
Although the owner is
Yeah.
fractures.
You see, that should be attached down here. Those things that should be attached down here.
And the end of the owners here.
Yeah. So that's a really severe fracture.
Yeah.
Hi there. The patients I'm pretty sure will all be on. They won't do much on it, but too hard. They'll all be on, I'm sure. No doubt. I mean, look, basically, what's happening is, Laura is making the one patient that should go across both tests. And I'm going to meet with her, in fact, this week, but I'll make sure it's handled, because they'll all be okay.
Thank you. That helps me a great problem.
Oh, yeah. Hi there.
Sir, I know you told me you had two stations. So one was for the clinical unit,
Yes.
and they told us about that. And so is the second station, it's with this unit,
Yes.
but it's not the X-ray, because the chest X-ray is on another day, isn't it?
No, this will be your chestoscopy.
Also, that's station two?
Yes, that's two. Yes.
So it's on the same day, isn't it?
Yes.
Okay,
Yes, yes.
right. So I was getting confused because I thought that the station two was a different type of OSCE for this one, not the chest.
No, that's right. See, originally the OSCE was set for week 13, so that all went out. But then Laura said no, it can't be because she has to combine her clinical mode. So she didn't tell me in time. So she didn't say in time to combine it. So it means that your original timetable is wrong because you see what happens is Laura wants to combine her element with it as well. So I think that's a good idea. So you'll have this practice of interpreting the test form and of course making sure you communicate adequately and doing the test OSCE before you go to clinical. So it works well.
So, first station clinical, like the form,
Yeah, that's right.
and second one, the actual
Yes.
form.
Yes, that's right. Yes.
Okay.
So it's a nice combination of both.
Yeah, that's pretty good.
It's all in one.
Works out.
So you've only got to do one for two tests. So it's great. Yeah. Hopefully it's good before. Yeah.
Good. All right.
And how seen Laura at all? Had much to do with Laura in terms of all the clinical staff there? Have you had many clinical lectures?
We've only had a couple. We've had but they've been more about like ethics and safety rather than.
Susan said giving a fair few lectures.
Oh, that's
Yeah.
good. Yeah.
Laura was just, she was, this week we had a prac on Friday with the hand washing, so she was supervising that.
Yeah.
But we haven't actually had lectures from her, but she's come in and just talked about like the course outline and
Yeah. I think Laura's going off very soon to have a baby.
Yeah, she is.
But, now that's good because, and look, those basic things are really important. You know, simple hand washing is so basic, but it's the most important thing you can do because hospitals contain bugs, they do. Having said that, look, I've never got sick at a hospital ever. I've never contracted one thing ever. And it's not hard to. All you need, it's just basic hygiene, that's all. And look after them, wear gloves and that. Now, in terms of ethics, is ethics good or is it a bit very varied?
No, it's good. It's just a bit dry, so it's hard to like stay focused. But no, it's good to hear it and it's good to read about it.
Yeah, I think it's interesting, but the question I always have is ethics as decided by who? Like who decides the ethics they give us? Is it? That's the thing, like, who decides? Who decides what they're doing? And then we all have common beliefs and common set of rules, but ethics is, well, it's a conversation.
Yeah, exactly.
Ethics is a conversation. That's
Yeah.
it's interesting, isn't it?
Yeah, it is. And they were teaching us about consequentialism and some like deontology. So yeah, what's right and wrong, because actually like you're going to end up, if someone's going to die, you're going to do it because it will save their life or go against their beliefs sort of thing. So
The good thing is, as far as radiography is concerned, we don't have to make those decisions.
yeah, exactly.
Now, basically, we respond. We're part of a medical team doing our job.
Yeah.
And there are only a couple of areas, and you may not even speak of these things. There are a couple of things, for example, things that I've seen over the years. Number one was sonographers who refuse to do patients having a dating ultrasound pre-abortion.
sorry, refused to do what, sorry?
Have a dating ultrasound, in other words, find the age of the fetus prior to abortion. And some sonographers have refused to do it. And that is my view is that medicine should be totally objective. And so in other words, I don't think it's appropriate for them. But then I know some sonographers. I think it's our job not to get involved in someone's ultrasound. Our job is to treat the patient at home. And I know some sonographers over the years have refused to do pre-rating ultrasound in that case. There is something else which isn't really ethical so much, but it's been done because it upsets people too much, and that's mortuary radiography, and particularly mortuary radiography of stillborn babies. And while that's very rare, and it depends on where you work, it only, of course, in big public hospitals, but some radiographers will refuse to do that because it's sensitive. And I think that's an ethics. And I think it's quite reasonable, but upset you don't do it. Because someone else will do it. So I should ask the clinical staff how they've had that situation of the sonographer refusing to.
Because we need to get everyone in, and do you sort of avoid giving the patients like sort of and they'll choose not to do.
But
They
then,
always have to give the information though, don't they? So that they have to know that might be thinking about like refuse to give that information as a patient, so you have to pass that on to the sonographer. Because they like possibly do know ultrasound without knowing that they were going to go off.
yeah, that's right, yeah.
Yeah, so you can always know what they hear.
You know, the world's such a... The problem is, I suppose, people try and make black and white rules because we need rules for everything to live, and that's true, but the problem is that the planet is grey. Everything's grey. So that makes it tough sometimes, doesn't it?
Alright, thank you so
Okay, I
much
see
for
you.
that.